Good evening, my dear students. Today, as you know, the subject of lecture is appropriate antimicrobial therapy in sepsis. For those who have attended the last lecture on early diagnosis and management of sepsis will well remember that sepsis is a body's response. It is a life-threatening organ dysfunction due to dysregulated host response to infection. Now, clearly, it means that infection is the key component here. And since infection is the key component, appropriate antimicrobial therapy is absolutely forefront in the management of sepsis. If we look into the 1-hour bundle, which has been suggested by the Surviving Sepsis Campaign guidelines, it clearly states these 5 steps which has to be initiated in all centers. 1, the measurement of lactate level, and to remeasure if the lactate is elevated for more than 2 after taking necessary measures. Obtain blood cultures before administering antibiotics. Administration of broad spectrum antibiotics. Begin rapid administration of 30 ml per kg of crystalloids for hypotension or lactate more than equals to 4 millimoles per liter, and apply vasopressors if hypotensive during or after fluid resuscitation to maintain the mean arterial pressure of more than 65 millimeter of Hg. Now, the very important thing to understand here is that after source control, the antibiotics are the mainstay of definitive therapy for curing sepsis. So, if we have to understand the antibiotics and their appropriateness in use during sepsis, we also need to understand some of the basic characteristics of the antibiotic usage, and that is the PK/PD. By PK, we mean the pharmacokinetics, and by PD, we mean the pharmacodynamics. Pharmacokinetics is what body does to the drug. Therefore, whenever there is an antibiotic, the action of the body towards this drug can be spelled out under 4 headings, ADME, that is absorption, distribution, metabolism, and excretion. And likewise, sorry, the pharmacodynamics, which means the drug's action to the cells or to the tissues or to the organisms, that can be defined as its concentration dependent. Concentration dependent means some drugs exert their cedal or static effect only depending upon the concentration that they reach above the minimum inhibitory concentration. Minimum inhibitory concentration is that concentration which will inhibit the growth of any microorganism in 50% of the cases. So the drugs which have a concentration dependent killing, their action is primarily dependent is how high or how higher than the MIC level they can reach. So in that case, the PD parameter becomes Cmax over MIC. Cmax is the maximum concentration. MIC is the minimum concentration. So Cmax divided by MIC is the determining factor for their pharmacodynamic effect. Likewise, there is another group of drug where it is not the concentration, but is the time duration above which its concentration remains above the MIC determines its killing effect, whether it is cedal or static. So in that case, the determining PK/PD parameter is T greater than MIC, where T denotes the time and MIC, as we know, denotes the minimum inhibitory concentration. There is a third group of antibiotics where we have to maximize the quantity that is delivered, and that is denoted by area under curve over MIC. So this denotes the killing effect of the antibiotic. That is the area of the time for which it remains above the area of curve. And in this, we usually need a loading dose alongside infusion. So this is the third form of action of the antibiotics on the organisms. So one, it is concentration dependent. Two, it is time dependent. And the third way is the area under curve over the minimum inhibitory concentration, or MIC. So this is what is the pharmacokinetic and the pharmacodynamic effect. Now, besides this, we also have to remember that for any antibiotic to act against any particular organism, only the in vitro report of sensitivity is not enough. That is, if the blood culture report shows that it has a sensitivity against a particular organism and the MIC values are within the acceptable range, it doesn't mean that this antibiotic is going to work unless it is ensured that the antibiotic achieves that concentration in that particular site. So the concentration of the antibiotic that is achieved at the site where it is destined to work, at the site of its action, also determines the activity of the antibiotic. Similarly, if that antibiotic is highly protein bound, then it is also important to see or check the protein level, the albumin level, or the binding protein, so that the antibiotic can reach its target site of action. So all these factors are very important. And since these factors are often dynamic, therefore, understanding these factors is very important to decide upon which antibiotic to administer, in what dose to administer, and for what duration to administer. If we overlook any of these, whether the pharmacokinetics, whether the pharmacodynamics, whether the concentration achieved, whether the antibiotic is able to reach the site of its intended site of action, it is worthwhile not to consider the antibiotic because it may fail. So, whenever we consider some antibiotics like penicillins, cephalosporins, carbapenems, macrolides, because we primarily have to understand that these have a time-dependent killing. So whenever there is a time-dependent killing, the optimal PK/PD index is T greater than MIC. So we have to maximize the duration of exposure, and therefore frequent administration or prolonged infusion dosing should be done so that the antibiotic level in the blood remains above the MIC for the maximum period of time. Similarly, for concentration-dependent killing antibiotics like aminoglycosides, fluoroquinolones, phosphomycin, colistin, etc., we have to maximize the concentration. Colistin has both this area under curve over MIC as well as concentration-dependent killing. So we classify it as under AUC and over MIC. Nevertheless, for aminoglycosides, for fluoroquinolones, we have to maximize the concentration, because once we are able to maximize the concentration, then it can be ensured that their efficacy as it at the peak. So they should be administered as a bolus dose and not as infusion. Whereas for some antibiotics, we require a loading dose followed by infusion. And these are the ones where we have to maximize the dose, because these antibiotics follow the PK/PD index of area under curve over MIC, and therefore the maximum amount of drug exposure to the organisms determine its killing effect. So if you understand these very basics, then only it will be possible to administer the antibiotic in the right form, in the right dose, and for the right duration. Because only knowing the antibiotic and the microorganism may not suffice always in achieving the means to an end. That is, you may choose the right antibiotic, but even the right antibiotic may fail. Even a good batsman may fail to score runs unless he has a understanding of the pitch, that whether the ball is turning, whether the wicket is slow, whether there is dampness, etc. So this is very important to understand. the effect of antibiotics and to choose antibiotics and determine their efficacy. Now, I will give you certain cases from which you will be able to understand how we have to choose the antibiotics. So this is apart from what I have already mentioned about the PKPD and the other characteristics based upon which even after choosing antibiotics, you will have to be selective on how to administer them. So what I'm talking now is the case-based approach to the choice of antibiotics. Now let us start with this case. The first case is a 30-year-old male admitted with cough, fever, and respiratory distress for 3 days. Patient is having tachycardia. The blood pressure is, however, normal, although the pulse pressure looks little wide. The respiratory rate is 35, so patient is having tachypnea. The saturation is fallen. It is 85% on room air. The blood investigation shows a TLC count of 14,000 with more than 90% polymorphs. The chest X-ray shows right lower lobe consolidation, with other investigations remain normal. Very simple, clear, and straightforward. I don't want to give any quiz because this is a case of normal thing, a case which normally we find the community-acquired pneumonia, one of the commonest cause of admission into the ICU. Now, how should one choose the empiric antibiotic? We know that if we choose the empiric antibiotic is the one which covers to most of the organisms that we can think of when we diagnose any particular condition. So we have to choose an empiric antibiotic, number one, which is likely to cover most of the organisms that are known to cause community-acquired pneumonia in our setup, and then taper it down or tailor it down to definitive antibiotic once we get the report of the cultures. And thirdly, de-escalate them timely once we know that they are no longer required or once the infection is under control. So all three steps together will determine the appropriateness of antibiotic therapy during sepsis. The beginning of empiric therapy to the institution of definitive therapy, and finally the de-escalation on the basis of clinical examinations, and if we have the opportunity to use biomarkers, taking the aid of the biomarkers. So in this case, when we see the community-acquired pneumonia, we have to know what are the common organisms causing CAP in India. And they are Streptococcus pneumoniae, gram-negative bacilli, atypical organisms, and viruses. So these we know are the common causes in any part of our country. And there are certain less common causes like Staph aureus, Legionella, and Mycobacterial tuberculosis. So once we know that these are the organisms, then we become that whether the patient is having any coexisting disease. This is a very important because Pseudomonas causes CAP in patients with structural lung disease. So what are the structural lung disease? Structural lung disease are the ones where there is some abnormality in the anatomy of the lungs. For example, in emphysema, in bronchiectasis, in COPD, but not in bronchial asthma, because in bronchial asthma, their unrelease is only in the hyper-responsiveness to the smooth muscle. So that is not a structural lung disease. So Pseudomonas aeruginosa causes CAP in patients with structural lung disease. MRSA and MDR gram-negative organisms, they are infrequent causes of community-acquired pneumonia in India, but they are also associated with structural lung disease. And another factor comes here is previous antimicrobial intake. So if a patient is having structural lung disease, along with a history of previous antimicrobial intake within the past 90 days, and more so in the past 30 days, particularly higher antibiotics, then we have to give considerations to these organisms too. Thirdly are the anaerobic organisms. Anaerobic organisms can also cause community-acquired pneumonia or co-infection along with other microorganisms in patients who have a risk factors for aspiration, like elderly because of their poor reflexes, cough reflexes, altered sensorium, again because of the same reason, dysphagia, head and neck malignancy. So in these patients, we can have pneumonia because of anaerobic infection or infection due to anaerobic organisms, either singularly or as co-infection. So likewise, in every patient, when we come with community-acquired pneumonia, if we know that what kind of organism is likely to be the cause of this infection, it will become easier for us to choose the appropriate antibiotic. Next, we have to know that what is the sensitivity of the organisms causing community-acquired pneumonia in India. If you look into the strep pneumonia, it remains sensitive to beta-lactams and macrolides. H. influenzae has a good sensitivity to beta-lactam and BL-BLI inhibitors, we call, that is the beta-lactam along with beta-lactamase inhibitors. For example, your piperacillin, tazobactam, cefoperazone, sulbactam, or yours even simply the amoxicillin, clavulanic acid. So these are all beta-lactam antibiotics along with beta-lactamase inhibitors, because organisms will produce the beta-lactamase which can destroy the beta-lactam and make the antibiotic ineffective. So a beta-lactamase inhibitor is given alongside the beta-lactam so that the beta-lactamases produced by the microorganisms are unable to destroy the antibiotic. So Haemophilus influenzae has a good sensitivity to BL-BLI and fluoroquinolones. However, recent studies have shown an increasing prevalence of ESBL producing Enterobacteriaceae, which means beyond this beta-lactamases, there is another form of enzymes which the microorganisms can produce to resist the effect of antibiotic, and which is also a cause of antimicrobial resistance, is called the ESBL, or the extended spectrum beta-lactamases. So in those cases, we will have to choose suitable antibiotics which can overcome the effect of such enzymes which are ESBL. That is the ESBL producing bacteria or not. So all these informations we will have from our microbiology colleagues. So wherever patient is there, these things are all reviewed subsequently, continually reviewed. It is a dynamic process that what organisms are growing in the ICU, whether these organisms are ESBL producing, to what are their sensitivity pattern, what is their specificity. So all these things as a continuous process which is monitored routinely in the ICUs to help the clinician decide on the best possible antibiotic. So what are the risk factors for multi-drug resistant community-acquired pneumonia in the ICU? So as I said before, that community-acquired pneumonia, if it is caused by strep pneumonia or H. influenza, we usually respond to BL-BLI, macrolides, or fluoroquinolones. That is the normalcy. But if this patient has received multiple antibiotics before, has a structural lung disease, was admitted in the ICU and then discharged home, he can acquire multi-drug resistant community-acquired pneumonia also and in the community. Although MDR is much common in hospital setting than the community setting, but still it is common. So if a patient is more than 65 years of age, if he has received antimicrobial therapy in the preceding 3 months, if he has a high frequency of antibiotic, if there is high frequency of antibiotic resistance in the community, for example, currently in our community for those discharged from the hospitals, there is very high resistance to the effect of fluoroquinolone. So if a patient has been on fluoroquinolones off and on in the hospital and was admitted in the hospital, subsequently discharged, develops a new infection, in all likelihood, he or she may have a resistance to this drug. Hospitalization for more than 48 hours in the preceding 3 months, home infusion therapy, including antibiotics, because now with home care, a lot of people are administered antibiotics at home, or patient may be on home wound care, chronic dialysis, etc. within 1 month. Family member has been affected with MDR pathogen, or the patient has been undergoing immunosuppressive treatment. So in all these patients, there is risk of multi-drug resistant community-acquired pneumonia. So in these patients, we will have to think about other antibiotics. So as I told you, what should be the preferred combination? So for patients with community-acquired pneumonia requiring ICU admission, a non-pseudomonal beta-lactam like cefotaxime, ceftriaxone, or this augmentin or amoxicillin clavulinate, plus a macrolide like azithromycin or clarithromycin should be preferred if there are no risks for pseudomonas infection. If there are risks for pseudomonas infection, as I told, the patient is having structural lung disease, a fluoroquinolone or an aztreonam in place of this macrolide will be more useful. And if macrolides cannot be used, then a fluoroquinolone may be used. If there is no suspicion, we know that in our country, the TB is very high. And because fluoroquinolone is also a reserved drug for tuberculosis, the incidence of XDR or extremely drug resistant TB or TDR, that is totally or pan drug resistant TB, is very high. And therefore, whenever we choose such drugs which are reserved for the purpose of tuberculosis, we have to be extra careful in choosing them. Their indiscriminate use for conditions other than TB can give rise to resistance for their use during tuberculosis. So the same happens with fluoroquinolones, and it should be considered. Now, who are the patients who are at increased risk of pseudomonas, and what should we do? So the risk factors for infections with pseudomonas include chronic pulmonary disease, that is COPD, asthma, or bronchiectasis, frequent use of systemic steroids. Many patients are suffering from a lot of other conditions, rheumatoid arthritis, etc., for which systemic corticosteroid is administered over a long time, or neurological disease also. Prior antibiotic therapy, old age, immunocompromised states, patients who are fed enterally, or patients on cerebrovascular or cardiovascular disease. So these are the patients who are at risk for pseudomonas, and we have to take adequate measures or caution during choosing the empiric therapy for CAP. If Pseudomonas aeruginosa is a etiological consideration, then anti-pneumococcal and anti-pseudomonal antibiotic like ceftazidime. Earlier, we had talked about cefotaxime. Now we are talking about ceftazidime, cefoperazone, piperacillin tazobactam, cefoperazone sulbactam, imipenem, meropenem. So these are all antibiotics which have both anti-pneumococcal as well as anti-pseudomonal effect. And combination therapy with the help of aminoglycosides or anti-pseudomonal fluoroquinolones. So this kind of therapy should be given to a patients who are at risk of pseudomonal infection, whether multi-drug resistant or not. Another important consideration is that who are at risk of MRSA. MRSA means methicillin-resistant Staphylococcus aureus. So we know Staphylococcus aureus is very common, and Staphylococcus aureus is one of the less common causes of community-acquired pneumonia. But even if it is the cause, treating it is very easy because it will respond easily to penicillin. Because most of these of the Staphylococcus aureus will not produce penicillinase, etc., and they will be susceptible to the normal antibiotics. However, if it is methicillin resistant, then this ordinary antibiotics or the ordinary anti-Staphylococcus aureus agents will not work. So the risk factors for MRSA include MRSA carrier or a patient, influenza, prisoners, professional athletes, army recruits, men having sex with men, IV drug users, regular sauna users, again, those with recent antibiotic use. So these are the various risk factors, and it should be suspected after influenza or in previously healthy young patients if there is cavitation or necrotizing pneumonia, which we can easily check in the chest X-ray, along with rapid increase of pleural effusion, or if the patient has massive hemoptysis or neutropenia or erythematous rash. So all this would point out to the chances of high chances of methicillin-resistant Staph aureus. So if MRSA is a consideration, then empiric vancomycin or teicoplanin should be added to the regime. Linezolid should be used for vancomycin intolerant patients, vancomycin resistant Staph aureus, or patients with renal failure. So these are the three common drugs. In addition to that, we also have other drugs like clindamycin, etc. But of note are that if you can remember that these three medicines, then probably they're very good enough. So for vancomycin, you will have to additionally remember that vancomycin, we have to monitor the trough level, that the concentration. We have to do a therapeutic drug measurement if we have. Otherwise, you have to be careful about the dose because it is likely to cause nephrotoxicity. We have to remember that with teicoplanin takes time, so we will have to give a loading dose always with teicoplanin. And with linezolid, we have to remember that it may cause a fall in the platelet, or it may cause a leukopenia at times. So if the patient's counts are below normal, or if the patient is having thrombocytopenia, then we should be used with caution. But however, this MRSA is less common in India, and when suspected, when there is a necrotizing or a cavitation in the chest X-ray, or there is a necrotizing pneumonia or rapid increase, then this should be suspected, in particularly in patients who have the risk factors, and this anti-MRSA agent should be used. Now, who are at risk for anaerobic infection and need anaerobic coverage? Now, from your basic understanding of microbiology, if you can remember, there are two kinds of organisms or bacteria, the aerobes and the anaerobes. Aerobes always need oxygen to divide. Anaerobes do not need oxygen. And in fact, the presence of oxygen can be harmful to them because they cannot divide. And there is a third group, which is called facultative anaerobes, which can divide without the presence of oxygen, but they will use oxygen if they have the access to it. So most are aerobic. We know that anaerobic includes primarily three groups. That is the Clostridium, that is the Clostridium perfringens, Clostridium tetani, the Clostridium group, the Bacteroides group, and the Fusobacter. There are others, but these three are primary. The facultative anaerobe is E. coli, and mostly others are aerobic. Now, whenever the patient has certain risk factors like dysphagia, altered sensorium, coma, witnessed aspiration, putrid discharge, presence of lung abscess, empyema, or necrotizing pneumonia, they run the risk of acquiring anaerobic infection. So the commonly prescribed empirical antibiotics for community-acquired pneumonia in ICU, such as ampicillin sulbactam, amoxicillin clavulanate, piperacillin tazobactam, they have excellent anti-anaerobic coverage. So there is no need to add, but sometimes people add metronidazole. Clindamycin and moxifloxacin are effective against aspiration and a lung abscess caused by anaerobic organisms, and lung abscess and necrotizing pneumonia may frequently, but the important thing is that they require often prolonged treatment up to 4 to 6 weeks. What should be the duration of antibiotic? This is also important. And in fact, many studies have been conducted to compare short duration versus long duration. And they have found that a short duration of therapy that makes no difference to the long-term outcome as against a long-term therapy. In fact, the long-term therapy runs the risk of causing antibiotic resistance. It runs the risk of causing drug toxicities in certain individuals, and it is also has cost implications. So therefore, early de-escalation is the rule. Whenever the infection is controlled and the primary purpose of administering the antibiotic has been served, it should be de-escalated and stopped. So patients with CAP requiring ICU admission should receive antibiotics for 7 to 10 days. This 7 to 10 days is chosen based upon the observation that either less than 7 days or more than 10 days is not going to make too much of a difference. In the between 7 to 10 days, if the antibiotic is appropriate, it usually gives the necessary effect or the necessary benefit. Patients with CAP due to Pseudomonas or aspiration pneumonia should be treated for 14 days. And necrotizing pneumonia due to gram-negative bacteria, MRSA, or anaerobes, they also require treatment for slightly longer period between 2 to 3 weeks. So this duration of treatment should be individualized according to the causative organism, the response, and the severity of disease and complications. Procalcitonin levels can be used with clinical judgment wherever facilities exist. The procalcitonin levels can be used for de-escalation of antibiotics in cap in the ICU treated beyond 5 to 7 days. Now, what should be empiric antibiotic of choice for VAP? In Indian ICUs, gram-negative organisms are the most common etiological agents because VAP is acquired in the hospital setting. And in the hospital setting, the commonest organism is gram-negative organisms. That is E. coli, Pseudomonas, Acinetobacter, Klebsiella. Many of them are multi-drug resistance. The frequency of specific MDR pathogens causing HAP and VAP may vary by hospital, patient population, type of ICU patients, and they can change over time. And that is why, as I told earlier, that it is very important to monitor the trend of the antibiotic usage, the trend in the organisms grown, their sensitivity and specificity pattern over a period of time to determine the or choose the antibiotic which serves best against any particular infection in sepsis. Now, risk factors for VAP due to MDR organisms include age over 60 years, duration of mechanical ventilation for more than 7 days, prior antibiotic use within 3 months, the presence of severe sepsis or septic shock at the time of VAP, if patient is having ARDS preceding VAP, if the patient has been on renal replacement therapy before VAP, and if the patient has been on systemic corticosteroid therapy. So these are the various risk factors for multi-drug resistant organisms causing VAP in hospitalized patients. Among patients with VAP who are not at high risk of MDR pathogens and in ICUs who have a low prevalence of MRSA and resistant gram-negative organisms, only one anti-pseudomonal antibiotic will suffice. However, among patients with VAP who are at high risk of MDR pathogens or in the ICU who have a high prevalence of MRSA and resistant organisms, an active agent against MRSA and at least 2 agents active against gram-negative organisms, including Pseudomonas aeruginosa, is recommended. I'm coming down telling once again that there can be a situation that the patient is having a low risk of MDR or a high risk of MDR. So when we see the patient is having a low risk of MDR, we next also see what is the prevalence of MRSA and resistant MDR in the ICU, whether they are more than 15% and 10% respectively or not. And this we can only know if we have the data of our ICU. That is why it is so important. So once we know that, if it is less than 15% prevalence of MRSA, less than 10% resistant gram-negative organisms, less chances of patient having high risk of MDR pathogen, then a single anti-pseudomonal. On the other hand, if any of this is high, then we have to give agent against MRSA and at least 2 agents against gram-negative organisms, including Pseudomonas aeruginosa. So this is the simple dictum which one needs to follow. Among patients with VAP who are not at high risk of MDR pathogens, but ICUs have a high prevalence of gram-negative organisms, then what we do, you give 2 agents active against gram-negative organisms. That is, the agent which was given against MRSA can be omitted because these ICUs do not have a high prevalence of MRSA or less than 15%. Most of the Indian ICUs don't have. Some, of course, can have. So in them, we can only give 2 antibiotics which are effective against gram-negative organisms, including Pseudomonas. In areas with high endemicity of tuberculosis, use of linezolid may be restricted unless no suitable alternative is available, because this is another important thing which one should remember. Like fluoroquinones, linezolids are also a reserved drug for tuberculosis, and hence their indiscriminate use should be restricted in non-tuberculosis situations, including MRSA. When to administer anti-pseudomonal drugs for complicated MDR, like prior use of antibiotics, prolonged duration of mechanical ventilation, COPD. So these all run the risk of complicated multi-drug resistant infections. So, or the complicated VAP in ICUs where a gram-negative isolate resistance is low and the patients have no risk factors. Here also, only one anti-pseudomonal antibiotic is enough. But when the resistance rate is high, that is more than 10%, then two anti-pseudomonal antibiotics from a different class has to be given. And empirical antibiotic regime for VAP should not cover atypical organisms routinely. Atypical organisms like Mycoplasma, Legionella, etc., for which we give other drugs. We give erythromycin, etc. So that can be avoided, should not be given routinely. So this is in a nutshell and how to choose antibiotic in patients who suffer from pneumonia, whether that pneumonia is community acquired, whether that pneumonia is ventilator acquired pneumonia, what are the risk factors for multi-drug resistant, how to choose empiric antibiotic in multi-drug resistance. You know, it is important to choose in empiric therapy should be perfect, because once the definitive therapy, the culture is known, then there is not much of rocket science in choosing, because then the only thing we will have to choose is that which antibiotic among those with shown sensitivities is likely to achieve the good concentration in the tissue. So if it is a lung infection, which antibiotic will achieve the maximum concentration in the lung, which will be absorbed and distributed in the lung, what will be its pharmacokinetics and dynamics, whether it will require protein to carry it for that site, and what is the level of albumin in that patient. So all those factors will suffice. But before definitive therapy, in empiric therapy, you will have to consider all these factors that I have mentioned. Let us go to another case, case number 2. 50-year male, a post-operative day 3 elective abdominal surgery, is having fever with chills and sweating for a day. On examination, there is redness and pain at the site of the right IJV catheter. Heart rate is 120 beats per minute, BP is low, respiratory rate is 30, saturation is 90% on room air. The TLC count is again 22,000 with more than 90% polymorphs. Chest X-ray is normal. The procalcitonin levels are 10. So this is indeed a case of catheter-related bloodstream infection, or what we call is the CRAPC. So what should be the empiric antibiotic in this patient? So what are the risk factors and therapy for CRBSI? This we have to know. The risk factors is long indwelling catheter duration. If a patient is immunosuppressed, patient is diabetic, patient is septic at the time of insertion of the catheter, multi-lumen catheters, Apache more than 23. So all these are important risk factors for catheter-related bloodstream infection. What are the organisms? The coagulase negative Staph aureus, Enterococcus, and Candida are the common organisms accounting for majority of the CRAPSIs, and a large proportion of Staph aureus and cons are methicillin resistance. There is increased incidence of CRAPSI due to gram-negative organisms, most of which are ESBL producers, which I mentioned about ESBL previously, and Candida, and among the Candida, it is the non-albicans Candida which are responsible. So, vancomycin or teicoplanin is the recommended first-line drug for the treatment of CRAPSI for MRSA and methicillin resistance, that is CONS, that is coagulase negative staph. And empiric coverage for gram-negative bacilli should include a 4th generation cephalosporins, a carbapenem, or a BLBLI with or without an aminoglycoside. So here you get a wide range of antibiotics. Probably in empiric, you have to give more than 1 or 2 antibiotics, depending, of course, on the severity of infection and the quick response, because many a times if this patient's the infection is not controlled quickly, the chances of moving to multi-organ dysfunction is very high. So depending upon the severity of the patient, you can choose whichever you may think of, or depending on the guide on the basis of ICU, and that which one will work best. But these are the various options. So what should be the duration of antibiotic treatment for CRAPSI? Minimum 2 weeks antibiotics should be given for uncomplicated, and 4 to 6 weeks for complicated Staphylococcus aureus, CRAPSI, and infective endocarditis. However, we can always monitor them by doing a regular blood culture and also by following up with procalcitonin. If we know the baseline value of procalcitonin, then it will be a good indicator to show the trend. Absolute value of procalcitonin has got no role in diagnosing infection, but the trend of procalcitonin, if it is coming down in a patient who is already on antibiotics, if the trend is showing it is coming down, then de-escalation of the antibiotics can be started and should be started early. So this is the duration. Minimum 7 days of antibiotics should be given for gram-negative CRAPSI. 5 to 7 days are recommended for Cons bacteremia, and for suspected fungal CRAPSI, antifungal therapy should be for 14 days. So all these recommendations are valid only when you are also looking after the other clinical examination, biomarkers, culture, etc., to support your therapy. Let us go to this third case. A 45-year-old female, post-operative day 3 elective gynecological surgery, comes with fever, with chills, sweating, lower abdominal pain for 1 day. On examination, there is inflammation around the urinary catheter site. Urine is dark. Patient is having a heart rate of 110 per minute. Blood pressure is normal. Respiratory rate is normal. Saturation is nearly normal. The TLC count is very high. The chest X-ray is normal. The urine is cloudy with presence of pus cells. And most importantly, the patient is having increasing severity of lower abdominal pain. So this we consider as a COTI, or catheter-associated urinary tract infection, or urosepsis. So what should be the empiric antibiotic? So again, you have to know what are the organisms. The most of the organisms causing UTI in ICU or in hospital setting are the gram-negative, primarily the E. coli or the Klebsiella, and sometimes the fungi, particularly the Candida albicans. And the risk factors for this UTI include the duration of catheterization, length of ICU stay, prior antibiotic use, higher severity score, female gender. The initial choice of antibiotics should cover for ESBL producing gram-negative organisms, and this includes aminoglycosides, BLBLI, or carbapenems. In the initial treatment regime, antibiotics against gram-positive organisms are not recommended because they are not responsible for urosepsis in the primary place. And in appropriate clinical settings, like if a patient is on immunosuppressive therapy or on long duration of steroids, etc., antifungal can be considered in the empirical regime. Coming to another case, let us see. A 45-year-old male was admitted with polytrauma and was on antibiotics for 10 days. Patient develops fever, loose motion. On examination, shows pallor with cold extremities. Heart rate shows tachycardia. BP shows hypotension. Respiratory rate is slightly more than normal. Saturation seems to be normal. The TLC is high, again with more than 90% polymorphs. The chest X-ray is normal. So what is this condition? So probably we are doing a condition of antibiotic-associated diarrhea, which is very common in the ICU, and Clostridium difficile is often caused. So this is also something where we should know the empiric antibiotic, because what are the organisms causing acute infective diarrhea in the ICU? Majority of the cases are non-infectious in etiology, and Clostridium difficile is the responsible for the majority of the infectious causes of diarrhea. So once we know that it is infectious or non-infectious, our treatment becomes easier. Risk factors for development of Clostridium difficile include prior antibiotic therapy, advanced age, prolonged stay in the ICU and the hospital, immunosuppression, use of proton pump inhibitors, enteral feeding. So we have to be careful with all these risk factors. The antibiotics which are implicated: cephalosporins, clindamycin, fluoroquinolones, carbapenems, and penicillin derivatives. Empirical use of metronidazole with diarrhea suspected due to Clostridium difficile in the ICU setting results in significant symptomatic improvement. So only this line of approach should be shown when we know that the diarrhea is infective diarrhea. Now, another important thing is that if we know Clostridium difficile, everyone knows that the drug of choice is vancomycin and not oral metronidazole. So how to compare oral vancomycin and oral metronidazole in treating Clostridium difficile infection? Now, metronidazole is preferred as the first line of treatment for mild to moderate Clostridium difficile or antibiotic associated diarrhea or Clostridium difficile associated diarrhea, while vancomycin is recommended as first line of treatment of microbiologically proven severe CDI. So this is the difference, that we can start with metronidazole, but if it doesn't respond, we can upgrade to vancomycin. So next is the fecal microbiota transplant. It is used in many places. It is available in our country as an alternate treatment of recurrent Clostridium difficile infection. The implicated antibiotics should be discontinued as soon as feasible clinically. Probiotics should not be recommended as an adjunct. Most often we see probiotics are used and pre-probiotics are often combined, but this is not a judicious for always. Addition of vancomycin to a patient with microbiologically proven Clostridium difficile infection, if the patient is already on metronidazole or has no response to metronidazole within 3 to 4 days, is very much required. Moving on to another case, a 40-year-old female, known case of gallbladder disease, for 2 years under conservative treatment, develops fever, pain, and jaundice over 2 days. ERCP confirms her CVD calculus. Accordingly, a stenting is done. Initially, patient settles down but develops fever spike on day 2. The tachypnea, there is heart rate is 120, there is hypotension, tachypnea, saturation is falling, TLC counts are very high. The USG shows cholangitis with mild ascites. So definitely this is a gram-negative infection. This is ascending cholangitis, which is very common in patients of post-ERCP patients, in stented patients. So what should be the empiric antibiotic of choice? Again, we have to understand the incidence, risk factors, and microbiology of biliary sepsis in the ICU. In the setting of acute cholangitis, it comes to around 0.2 to 10%. That is a wide range. So all the patients who are having cholelithiasis, choledocholithiasis, either strictures, whether benign or malignant, in whom's interventions in the common bile duct are performed, they run at the risk of cholangitis. And whenever there is cholangitis, it is the gram-negative organisms which are most common. Then they are also isolated from the patients in culture. But before that, most of the pathogens isolated are susceptible to third generation cephalosporins like cefoperazone sulbactam, aminoglycosides, uridopenicillins, and carbapenems. So either BLBLI, cefoperazone sulbactam, or piptaz or piperacillin-tazole or carbapenems as monotherapy in patients with moderate to severe cholangitis is recommended. And one should remember that biliary drainage, PTBD we say, or cutaneous biliary drainage, should be considered in all patients with cholangitis in addition to empiric antimicrobial therapy, because source control is more important than antibiotic. So what are the empirical antibiotics of choice for treating peritonitis? This also is a very important consideration, that gram-negative enteric organisms are common causes of primary and secondary peritonitis. So other organisms include gram-positive as well as anaerobic bacteria. The organisms most commonly isolated in tertiary peritonitis, that is the peritonitis which developed after 7 days of treating secondary peritonitis. They are Candida, Enterococcus faecium, and Staph epidermidis. So third generation cephalosporins are most effective antibiotic therapy for primary peritonitis, and usually they are required for 7 to 10 days. Again, they can be followed up with culture and biomarkers. Most of the organisms isolated in secondary peritonitis are sensitive to BLBLI or carbapenems. For gram-positive organisms, vancomycin and linezolid are effective treatment options. The short duration of treatment is as effective as long duration after source control. So once the source control is performed, there should expected not to be any difference between long-term and short-term therapy. And therefore, as soon as the infection is controlled, one should go for de-escalation. In this connection, another important consideration is liver abscess. And it is important to know what are the organisms which cause liver abscess and what is the empiric antibiotic of choice. So amoebic liver abscess is the most common cause of liver abscess in India. For the non-amoebic causes, gram-negative organisms like E. coli and Klebsiella are the most common organisms. The risk factors include diabetes, older age, male gender, biliary diseases, biliary procedures, alcoholism, malignancy, intra-abdominal infection, previous cystic lesions in the liver. And metronidazole is the drug of choice for treatment of amoebic liver abscess. And the optimal duration in patients with amoebic liver abscess is 10 to 14 days, whereas BLBLI, metronidazole, and carbapenemase are effective antibiotics for pyogenic liver abscess. And in such cases, the antibiotics are also required for prolonged periods ranging from 2 to 4 weeks. So it is very important to consider the albumin levels also in these patients, because although we administer IV, but ultimately the antibiotics reach their site of action, that is the liver in bound form, and for which the amount of albumin is necessary. Let us come to another case. A 30-year-old male presents with low-grade fever, altered sensorium, and vomiting for 2 days. On examination, shows neck rigidity and meningism. On heart rate is around 70s. GCS is E2M5V4. Heart rate is 90 per minute. Blood pressure is normal. Saturation is apparently normal. That is 90% on room air. On investigations, the TLC is mildly raised. The CT head shows dilated gyri and sulci. MRI shows low intensity T2 weighted signals in temporal and the occipital lobes. So most probably here we are dealing with a case of meningitis or a meningoencephalitis. Whatever is, it will be clear in the MRI subsequently. So what should be the empiric antibiotic of choice? So we should know that what are the common organisms causing acute bacterial meningitis in the ICU. So the common causative organisms are strep pneumoniae, Neisseria meningitidis, other streptococci, H. influenzae, Listeria monocytogenes, and less common organisms include staph, gram-negative bacilli, pseudomonas, and the acinetobacter. Risk factors for community-acquired meningitis, if patient is coming from the community with this, is otitis media, elderly population, depressed immune status, prior use of antibiotics. So initially, third generation cephalosporin plus vancomycin is the empiric antibiotic of choice for community acquired, and ampicillin or amoxicillin should be added if age is more than 50 years. If beta-lactams are contraindicated, chloramphenicol by vancomycin is done. Chloramphenicol has been discarded long time back, but again, it is resurfacing as a new antibiotic, just like colistin did some years back. So chloramphenicol is also being explored in a new way. And cotrimoxazole if the patient is elderly, their age above 50 years. Now, how different are the antibiotics chosen for nosocomial? That if this patient is coming from the community, we know we have a third generation cephalosporins in our hand, to which we can combine a few of the other options that we showed. But if it is acquired itself in the nosocomial meningitis, in the hospital, most of these patients who develop meningitis, they usually have a ventricular drain or a catheter. And the commonly organisms are coagulase negative staph, Staph aureus, Acinetobacter, Pseudomonas, and the Enterobacteriaceae. So risk factors include repeated catheterization, long duration of catheter, CSF sampling, presence of concomitant systemic infection and surgical technique, etc. So here, vancomycin plus cefepime or ceftazidime or meropenem is the empiric antibiotic of choice, because here we primarily have to cover the gram-negative organisms. And intraventricular or intrathecal antibiotics should be considered if infection responds poorly to the appropriate systemic antibiotics, because in many of these patients, the blood-brain barrier is impaired. So therefore, the antibiotic is not able to cross the blood-brain barrier. So intrathecal administration of or intraventricular administration of antibiotics may help. What should be the duration of therapy for meningitis? Duration is based on suspected or isolated organisms. So 10 to 14 days for Streptococcus pneumoniae, 14 to 21 for Streptococcus agalacti, 7 days for Neisseria or H. influenzae, 21 days for aerobic gram-negative bacilli, 21 days for Listeria monocytogenes. So depending upon their suspicion and the growth as revealed by the microbiology, we will have to decide. Of course, alongside, we will have to see the clinical improvement, the response, the fall in the counts, etc. If no microorganism is identified, treatment should be given for 10 to 14 days, that if the culture is sterile. Brain abscess, the most common empiric treatment is of third generation cephalosporin combined with metronidazole, and the antibiotic duration ranges maybe from 4 to 8 weeks. Again, it will depend upon the response, how quickly the brain abscess, because that site is difficult to reach by the antibiotics, so it takes time. Colistin may be given if the incidence of carbapenemase resistant Enterobacteriaceae or drug resistant Enterobacter is very high in the unit. So I avoided discussion about colistin because colistin, polymyxin, tigecycline, these are our last line drugs, and their inadvertent use is giving rise to a lot of problems in the management of the patients, because by the time a patient reaches in the ICU, it is often seen that these drugs has been administered in the primary or the secondary level, either outside or in the ward. So it becomes very difficult to find a suitable antibiotic for such patients. So I avoid it. But you have to remember that colistin has to be used judiciously only in those cases where other drugs fail. And also we will have to understand that colistin has a low volume of distribution. It stays primary in the blood. So if the blood culture is positive, it is good. If the blood culture is negative, but some other sites such as the lungs, the pancreas, then we will have to use a very high dose of colistin to achieve a concentration. So loading dose followed by high dose, 9 million units of colistin is required to achieve its concentration otherwise. So what are the most common organisms? Another very common cause of infection leading to sepsis is the skin and subcutaneous SSTI. So Staph aureus and gram-negative bacilli have been commonly implicated for skin and subcutaneous tissues infections in India. And among the gram-negative, Pseudomonas and E. coli are most common pathogens. Necrotizing fasciitis is caused by Streptococcus pyogenes in its monomicrobial form. Clostridial species are also responsible for monomicrobial necrotizing fasciitis. Old age, obesity, diabetes, malignancy, higher Apache score, longer ICU stay, end-stage kidney disease, liver cirrhosis, IV drug abuse, neutropenia, all of these are the risk factors for skin and subcutaneous tissue infections. So what are the empirical antibiotics of choice for treating SSTI? For moderate, non-purulent SSTI, IV penicillin or clindamycin is the first choice. For severe non-purulent SSTI, either a combination of piperacillin tazobactam along with coverage for MRSA, along with concomitant surgical inspection or debridement if required. For severe purulent SSTI, IND, that is incision and drainage, followed by empiric antibiotics including piperacillin tazobactam, along with MRSA coverage, penicillin plus clindamycin for monomicrobial necrotizing infection caused by Streptococcus pyogenes or Clostridium, and a combination of piperacillin tazobactam, fluoroquinolone, and clindamycin for polymicrobial necrotizing fasciitis. So this platter is there. You will have to choose one from them based upon your clinical diagnosis. Now, this is very important to understand that what are the risk factors for invasive fungal infections in the ICU, because most of the time we might have to use antifungal medications, and it is seen that if we use antifungal medications early in patients who need them, their outcome is better. So the risk factors for invasive fungal infections in non-neutropenic patients in the ICU are surgery, total parenteral nutrition, RRT, if the patient has been on cardiopulmonary bypass for more than 2 hours, diabetes, CVC and the urinary catheters, if candida colonization and colonization index of more than 0.5, use of broad spectrum antibiotics, patient was on acute renal failure, patients on mechanical ventilation for more than 3 days, or Apache 2 score of more than 16. So a host of factors are there, and there is a scoring system, Candida score. I'm not going into details because it will take time. Among the fungal pathogens, Candida species are most commonly isolated microorganisms, and in India, the Candida albicans ranges from 34 to 45%. It has an attributable mortality which is quite high, almost equal to some of the bacterial infections. The incidence of non-albicans Candida is on the rise, and it has a attributable mortality which is even higher than the Candida albicans, and the higher mortality is seen with Candida krusei, and of course the recent threat to most Indian ICUs from the Candida auris. So what is the antifungal agent of choice and duration of therapy? So here we are talking primarily the non-neutropenic patients, because neutropenic patients have several other considerations. So fluconazole and caspofungin are useful as empirical antifungal therapy in non-neutropenic settings in patients at high risk of invasive fungal infections. In India, the rate of fluconazole resistance is higher, and therefore, when the patient is sick or in multi-organ dysfunction, it may be good to start with echinocandins like caspofungin. Caspofungin may be preferred in areas with high prevalence of fluconazole resistant. Other alternatives like micafungin or anidulafungin may be used. The recommended duration is for 2 weeks. Empirical antifungals in patients with high risk of invasive fungal infections have been shown to reduce the incidence of subsequent proven invasive fungal infections. Although we know that culturing of this will take time, it is difficult. Galactomannan is not available everywhere. So a clinical decision to start is very important in patients who have or who show high risk of fungal infections. Now, the important concept I state that it is not just the empiric therapy and followed by the definitive therapy, but it is also the antibiotic de-escalation that determines the success, and it is which also determines the long-term strategy in the ICU, because to prevent drug antibiotic resistance. So antibiotic de-escalation refers to the strategy of switching from broad spectrum to narrower spectrum, and it is recommended to reduce the emergence of multi-drug resistant bacteria as well as cost. Implementation of antibiotic de-escalation algorithm is based on serum procalcitonin measurements. It can be based on various biomarkers, but the one which is proven consistently in most of the studies is calcitonin. And this has been shown to reduce mortality, length of ICU stay, total duration of antibiotic days, and costs. So prospective audit and feedback strategy resulted in reduction in the utilization of antibiotics and significant cost reduction. So de-escalation is as important as choosing an appropriate antibiotic. So to end, my take-home message to all my students would be that International Surviving Sepsis Campaign guidelines for the management of sepsis and septic shock recommend IV antibiotics within the first hour of sepsis and septic shock. This is recognized, and you all know, and you should all go by these guidelines at least once in 3 to 4 months. Otherwise, you tend to forget some of the things. So the salient features of the guidelines should be very clear, or should be in your mind most of the at as much as possible. And use of broad spectrum and agents with good penetration into the presumed site of infection, which I told before, and reassessment of the antibiotic regimen daily to optimize efficacy, prevent resistance, avoid toxicity, and minimize cost is very important. The principles of empiric antibiotic treatment should be defined according to the most frequently isolated bacteria, always taking into consideration the local healthcare setting trend of the antibiotic resistance, because that varies from hospital to hospital, and even in the same hospital it varies. So many people earlier used to follow the antibiotic rotation policy. This rotation can be in two ways: either for a particular duration some antibiotics are used, and then for the next another period they are replaced, and then they again return, or it is on the basis of patients, that is for first, fifth, and seventh in certain ordered manner antibiotics are changed. So, but it has not been found to be in the studies proven to, or there are not enough evidences that antibiotic rotation is most successful strategy. But similar strategies are essential to understand the cause of resistance and also to minimize resistance in the ICUs. So appropriate antibiotic therapy in critically ill requires more specialized considerations than just selecting the most suitable antibiotic. So as I told you, that we need to understand our patient much better, much more clinically, as well as on the basis, interpret the reports based on the clinical findings, choose the antibiotics, knowing our ICU environment, the sensitivities, the susceptibilities, the resistance pattern, what is the kind of the organ dysfunction in this particular patient, and how rapidly or quickly it is likely to progress. So all of this combined to give us the appropriate antibiotic for sepsis. And only when we do that, we are able to give safely recruit most of our patients and prevent them from going to shock. So thank you. If there are any questions, I am ready to take.